Hello and welcome back to Obcast. The topic for today is going to be red cell alloimmunisation, and I think it's important we have a good understanding of the basics of this condition, as its prophylaxis and preventative measures are commonly done by a lot of doctors. Now, in pregnancy, women are routinely screened for their ABO group, their rhesus status, and also they're screened for any atypical red cell allo antibodies, and we'll talk about what some of those are shortly. I guess the important concept is beyond just the woman's rhesus status, there are many red cell antigens that can cause alloimmunisation, and some of them are associated with severe hemolytic disease in the fetus. Now, the RHD antigen is the most common, but others that you do see not infrequently include the anti-C antibodies and the anti-K antibodies. And there's some others that we'll tabulate shortly just for future reference. Now, simply put, the consequences is that some of these antibodies can be associated with hemolytic disease, and at the mild end of the spectrum that can just lead to jaundice in the early neonatal period. But some of these antibodies can lead to severe hemolysis, which causes fetal anemia and high output cardiac failure in utero, which is known as hydrops fetalis, and this can lead to intrauterine fetal death. Some ways that we can evaluate women for these issues are that if antibodies are found on their screen, their titers are measured serially, and if it seems to be that there is an increasing amount of the antibodies, then further evaluation can be done in the form of either an ultrasound, looking at the middle cerebral artery Doppler flow, or even fetal blood sampling can be done to directly look for the fetal hemoglobin level and presence of hemolysis. I wanted to include these two tables, really just outlining all the various red cell groups that can cause isoimmunisation, and some of the ones that cause either milder disease or that do not cause disease, And this is really just for people's future reference if they come across an antibody that they've not heard before. Now, just to narrow down on the rhesus side of things, Rh immunoglobulin is something we prescribe, weekly in all of our practices at least. And just a bit of history, it was developed in the 1960s, and the reason is about 15% of Caucasians, both in Europe, North America and Australia, are Rh negative. And historical studies have shown that administration of Rh immunoglobulin to women who are rhesus negative has significantly reduced the sensitization in subsequent pregnancies. Now, it's historically thought around 15% of pregnancies would be sensitized, and now it's down to less than 1%. And in terms of routine administration of Rh immunoglobulin, it's currently given at 28 and 34 weeks at a dose of 625 international units. Now, it's also indicated for sensitizing events, and this is just any time there's a potential for mixing of maternal and fetal blood. Now, this includes bleeding in early or late pregnancy, trauma to the abdomen, procedures such as external cephalic version or chorionic villus sampling, even delivery. And anti-D ideally should be given within 72 hours for maximal efficacy during these sensitizing events. But if it's delayed up to 9 or 10 days, the thought is that there probably still is some benefit. Now, it must be said there is some controversy around the use of Rh immunoglobulin in early pregnancy, and various centres, their guidelines for administration do differ. We do know that sensitisation does occur in first trimester. Now, it's thought that about 0.1 of a mil of blood is needed to cause sensitisation, and that on average, by 8 weeks, there's usually about 0.3 mils of maternal blood in the fetal circulation. So there really is the opportunity for sensitisation to occur early. Having said this, there's a lack of evidence that there is maternal antibody formation from sensitizing events in the first trimester, or there's a reduction of alloimmunisation from anti-D administration in small randomised control trials in early pregnancy. I think knowing this is important and acknowledging the controversy, but just understanding that it's probably best to operate within the guidelines of your institution, and that these things are probably going to be something that change over the next 5, 10, 15 years. You know, certainly it used to be common ground for any bleeding in early pregnancy to receive RH immunoglobulin. But there is a trend now for women only requiring surgical management of miscarriage or ectopic pregnancy to receive RH immunoglobulin. But this is very centre dependent and something that you should check your local guidelines and really operate within that framework, because this is a controversial area. So they're the basics of red cell alloimmunisation, and really all that I wanted to talk about today. I hope this has been helpful, and thanks very much for listening to Obcast.